Hello, my name is Kate Tipping and this is a pathophysiology video on anemia. So we're going to talk about what is anemia, the symptoms, the pathophysiology, clinical examination, history, and then we're going to have a summary. Okay, so what do you already know? What nail sign may present with chronic anemia? And a useful tip for your OSCEs is to know 2 or 3 nail signs for each system. So is it clubbing, koilonychia, splinter hemorrhages, or tar staining? And the answer is koilonychia. Okay, what is the function of hemoglobin? And again, I've said this before, don't forget to ask lots of questions on clinical placements. With permission, have a look at the patient's notes and see what investigations have been ordered, why, what are the results of those investigations, and what they mean. Okay, and the function of hemoglobin, does it break down lipids? Is it for the delivery of oxygen to the tissues from the lungs? Does it raise the level of glucose in the blood? Does it stimulate the gallbladder to contract? And the answer is delivery of oxygen to the tissues from the lungs. What are common symptoms of anemia? Fever and nausea, widespread rash, photophobia, which is dislike of bright light, and aching joints, or constipation, flatulence and abdominal cramps, or fatigue, shortness of breath and poor ability to exercise. And think about the fact that anemia is caused by decreased levels of hemoglobin in the blood. Think about what impact that would have on the body. And the answer is fatigue, shortness of breath and poor ability to exercise. Okay, anemia is defined as a low hemoglobin concentration. Anemia is the most common blood disorder affecting about 1/3 of the global population. It may be due to reduced production of red blood cells or increased loss of red blood cells, and it has many causes. The first step when classifying anemia is to look at the mean corpuscular volume, so the MCV. Anemia can be classified as microcytic, macrocytic or normocytic. So you can have low mean corpuscular volume, so less than 80, which is microcytic anemia. You can have normal, between 80 and 90 femtoliters, which is normocytic anemia, so it's a normal average red blood cell size, or high MCV, so more than 96, and that would be classed as microcytic. So microcytic anemia, low mean corpuscular volume. Erythrocytes, so red blood cells, are usually hyperchromic under the microscope, so that means that the red blood cells appear paler than usual. So you may hear people describe this category of anemia as microcytic hyperchromic anemia. So for each of the categories, I would try to learn 2 as a minimum of different types. In microcytic anemia, I've done 2 examples. So iron deficiency is a cause of microcytic anemia. And iron deficiency could be caused by heavy menstrual bleeding, gastrointestinal tract malignancy, pregnancy, celiac disease, or a diet which is low in iron. And thalassemia, it's a genetic condition and it causes problems with globin chain production, and this subsequently alters hemoglobin synthesis. Normocytic anemia, so normal mean corpuscular volume. It's defined as an anemia with an MCV within the normal range, 80 to 96. However, the hematocrit is the volume of red blood cells in the blood, and the actual hemoglobin is decreased. It can be caused by acute blood loss, anemia of chronic disease, sickle cell disease, hereditary spherocytosis, glucose 6-phosphate dehydrogenase deficiency, vitamin B2 or B6 deficiency. And it can also be a mixed picture. So a patient could have iron deficiency and B12 deficiency. So you can have like a microcytic and a macrocytic, but gives an average red blood cell size that's normocytic. So always think about that as well. Macrocytic anemia, so where the red blood cell has got a high mean corpuscular volume. The larger red cells are always associated with insufficient number of cells and often also insufficient hemoglobin content per cell, which is anemia, low hemoglobin. So both of these factors work to the opposite effect of larger cell size, so they result in a total blood hemoglobin concentration that is less than normal. So very few big cells, but with insufficient hemoglobin. And the way to remember it is fat red blood cell, fat RBC. So folate deficiency, alcohol, thyroid, hypothyroidism, reticulocytosis, B12 deficiency known as pernicious anemia, and cytotoxic drugs. Again, so just you can either remember fat RBC or you can remember two of those from the list. Symptoms of anemia. As we talked about before, common symptoms are fatigue, shortness of breath, laboured breathing, known as dyspnea, poor ability to exercise and palpitations. Other symptoms, and it does depend on the severity of the anemia, can include headaches, depression, irritability, confusion, feeling faint, increased thirst, and loss of consciousness. Now, the pathophysiology, I've only listed a few here as examples. Overall, anemia can be due to blood loss, decreased red blood cell production, or increased red blood cell breakdown. So decreased levels of hemoglobin. Now, the pathophysiology is quite complex and it's not something we're going to be able to cover in a 15-minute video. I'm going to give you a couple of examples for the anemias. And at the bottom, I've put the source Robbins' Basic Pathology. Is a really good book that goes into a lot more detail about what causes the actual anemia. So in iron deficiency, ultimately the capacity of the red blood cells to synthesize hemoglobin, myoglobin and other iron-containing proteins is diminished, and that leads to microcytic anemia and eventually will lead to impaired cognitive performance and maybe even reduced immunocompetency. You've got hemolytic anemias, which are both microcytic anemias. So you've got the G6PD deficiency, which is an X-linked disorder caused by mutations that make the red cells susceptible to oxidant damage. And you've got thalassemias. So again, that's a genetic condition. Ultimately, it's mutations in the alpha or beta globin, and it reduces hemoglobin synthesis and impairs further erythropoiesis, which is the production of the hormone from the kidneys. For the anemia of chronic disease, normocytic anemia, it's the most common form of anemia in hospitalized patients. So it resembles iron deficiency, but arises instead from the suppression of erythropoiesis by the systemic inflammation. So, because the inflammation blunts the hormone synthesis by the kidneys, the bone marrow then doesn't produce or only produces very few red blood cells. So then you will get fewer red blood cells, fewer hemoglobin, and overall anemia. Microcytic anemia is the folate and B12 deficiency. So because you've got deficiencies of folate or vitamin B12, it leads to inadequate synthesis of thymidine and defective DNA replication. So this results in enlarged abnormal hemopoietic precursors and again ineffective hemopoiesis, so production of the red blood cells. So as I said, it is a very broad subject, and I would pause these slides, I'd jot down a few notes, and then I would go and have a look in a pathology book for more information on the pathophysiology of anemia. But for this, you need to know that it's caused by reduced hemoglobin concentration. Okay, so clinical examination and history, what are you looking for? So when a patient comes in, a full blood count should be done. When you do that, you'll be looking at the mean corpuscular volume, the mean cell hemoglobin, ferritin, iron, and total binding capacity. A blood film or peripheral blood smear is usually undertaken to have a look at the blood cells and look at them under the microscope. you need to look at the cause of the anemia. So why has this happened? And you might do something like an endoscopy, stool microscopy, or barium enema. And always, if the patient's complaining of palpitations, chest pain, any cardiac problems, always carry out an ECG. In severe anemia, there may be signs of hyperdynamic circulation, so the patient might have tachycardia, they might have flow murmurs, they might have cardiac enlargement. And when you're taking a history from a patient, ask them about exercise tolerance. Have they been feeling unusually tired, and whether they've experienced shortness of breath. And also ask them about their diet. Do they have a diet that's rich in iron? Or are they lacking? Are they not eating very well? Are they underweight? Or are they overweight and they've just got a very poor diet? So find out exactly what it is that they're eating. So OSCE tips. Okay, so pallor, the patient may be very pale. This is usually in chronic anemia. Koilonychia, which is the picture on the right of the person's finger, you can see the nails are spooned. So again, that's a sign of chronic anemia. And they might have conjunctival pallor. So if you ask them to pull down on their eyelids and to look up, you'll see a pale inner surface of the eyelid. They may have what's known as atrophic glossitis, which is a bald tongue, which you can see on the left. So tender, smooth tongue. They might have, there's two different words for it, but I usually say angular stomatitis, which is inflammation and crusting around the corners of the mouth. So you can see it in this patient here, the crusting around the edge of the mouth. Okay, so what did you learn? So what nail sign may present with chronic anemia? Is it clubbing? Is it koilonychia? Is it splinter hemorrhages? Or is it tar staining? And the answer is koilonychia. What is the function of hemoglobin? And this is very important in understanding why this decreased level of hemoglobin actually causes the symptoms that it does. So does it break down lipids? Is it delivery of oxygen to the tissues from the lungs? Does it raise the level of glucose in the blood, or does it stimulate the gallbladder to contract? And the answer is delivery of oxygen to the tissues from the lungs. And finally, what are the common symptoms of anemia? Fever and nausea, widespread rash, photophobia and aching joints, constipation, flatulence and abdominal cramps, or fatigue, shortness of breath and poor ability to exercise. And the answer is fatigue, shortness of breath and poor ability to exercise. And that's it. Thank you for listening. And as I say, if you go away and have pause this presentation, read through the pathophysiology slides, and go away and do some more in-depth research into the pathophysiology of all the different types of anemia. Thank you for listening.